Good morning. Welcome to day 2 of the CMREN Lunch and Learn, Substance Use Disorder in the Subpopulations. We're very excited to have you join us today. My name is Gail Bullard, and I am the Project Director for CMREN. As you'll see on your screen, you can claim CME and CE credit for today's event. I will add this email to the chat box for you so you can have it available while we are going through the conference and after. And but we encourage you to claim your CME or CE credits as you wish. Now, for a little more housekeeping, today we will have a Q&A session following Ms. Bielby's presentation. And so throughout the presentation, if you think of a question, please put it in the Q&A box, in the question and answer box. And then after her presentation, we will spend the last 15 minutes or so answering those questions. So again, the CME information will be in the chat box, but questions and answers go in the Q&A box. So thank you so much, and I look forward to seeing all of those questions. So today, our speaker is Miss Chloe Bielby. Chloe is a pathology analyst at Western Michigan University's Homer Stryker MD School of Medicine. Chloe has presented to CMREN a couple of times, and we met Chloe at the Michigan Department Health and Human Services MODA, the Michigan Opioid Data Analysis Project. And Chloe, we're so excited to have you present to us again today. So the floor is yours, Chloe. We'll end about after about 40 to 45 minutes and then have Q&A.
There we go. So now you should see my presentation. My name is Chloe Bielby. And again, I work at the Homer Stryker School of Medicine at Western Michigan University. I'm the pathology analyst there, and I work with the overdose deaths. I have no conflicts of interest to disclose. So I just want to quickly go over what the medical examiner process is. Some people may not be familiar, so we can all be on the same page. So the medical examiner does death investigations in the community that they serve, where a medical examiner investigator that we call MEI for short, they will go to the scene and evaluate the scene, learn the circumstances of death. And if they determine that the individual who died, it was an unexpected or suspicious death, then an autopsy is performed by a pathologist at the med school. And the pathologist will then review all the records of that decedent, so police reports, EMS run sheets, medical records, and then if it's something about elder abuse, they'll review APS documentation. And from all those records, they will determine cause and manner of death. And so then my purpose in the office, again, is to disseminate the drug-related death information. So I read all of those records, I put it into my spreadsheet, and then I create reports and then presentations like this with the hope of lowering the number of overdose deaths that are happening in our communities. So our office in 2018 served 11 counties, and in 2019, Berrien County was added for a total of 12. We stayed at 12 for 2020, and then in 2021, we added Cass County. But the purposes of this presentation, Berrien and Cass County are going to be excluded. Obviously, Cass County is excluded because 2021 just started, and there's very little data so far. But I wanted to include 2018 in this presentation, so I excluded Berrien County so that the numbers wouldn't be skewed. Visually, we work with the western counties in Michigan, so Allegan, Barry, Calhoun, Grand Traverse, Kalamazoo, Leelanau, Mason, Muskegon, Osceola, St. Joe, and Van Buren, a variety of rural and urban counties, and a variety of demographic makeups. And the population total is over just over. And so when we're doing presentations like this, it's important to know what the general population is compared compared to the study population. So I have the variables on the left, and then 3 years, 2018, 19, and 2020. And then the reference column refers to what the general population is made up of. So to start, in 2018 and 19, there was the same number of deaths, 214 overdose deaths. And in 2020, it increased by 20% to 254 deaths. The population, the general population is pretty much 50-50 male to female, but the male burden is increasing by about 4% every year, to the point where it's almost 75-25 male to female for fatal overdoses. And then as far as race, most of Western Michigan is white, almost 90%, but the burden on those who are Black is much higher than what their proportion in the general population is. Definitely a disparity there. And then I have the other category because they are so small, but they are made up of Pacific Islander, Native American, and Asian. And then we can see that the average age is early 40s. And I like to illustrate some of these tables in different ways just because people learn in different ways. So the colors, the orange, green, and blue refer to 2018 through 2020, and the black bars represent the general population. So we can see a gradual decline in the number of females fatally overdosing and a gradual incline of males fatally overdosing. And then on the right, we can see that disparity visually for especially the Black community, where there's a much higher proportion of those fatally overdosing compared to their makeup in the general population. And so total overdoses increased in 2020 for sure. There's no question about it. And to me, it was really apparent from March to June of 2020, kind of the beginning of the pandemic and when things started to get a little scary. We can see that the other years, 2018 and 19, they're intersecting. And then starting in July in 2020, that also intersects with the other years. Between March and June, there was about a 90% increase in overdose deaths compared to 2019. So that was very startling to our office to see that. It has gone back to baseline per se, not something that we need to let up on though. And so there's a lot of factors that influence fatal overdose. So we'll talk about those, and then I'll talk about any connection to COVID that they have. So we'll talk about highest level of education, using substances alone, employment status, living in an impoverished community, having a psychiatric disorder, suicidal ideation or suicide attempt, previous overdoses, healthcare access, and then being recently substance-free in the past 2 weeks before the fatal overdose. So this slide is to show you the layout that I have for the next series of graphs. So 2018 will always be orange, 2019 will always be green, and 2020 will always be blue. And then a lot of the graphs I will have 2 on each slide. So on the left will be an incidence graph, and on the right will be a percentage graph. So to give an example of what I mean by these 2 words is, let's say there's 15 overdose deaths in January of 2018, and 10 of these decedents use substances alone. On the incidence graph, I will plot 10 in orange for January. On the percentage graph, I will plot 66% for January, and that's because 10 divided by 15 is 66%. So we can see the actual number of people who exhibited that variable positively on the incidence graph. And then on the percentage graph, we take into account how many people died during that month. So for the first graph, we look at highest level of education, and that is being not having a high school diploma or a GED. We can see that about 25 to 30% of decedents never achieved a high school diploma or a GED, typically 5 to 6 decedents per month. This is important because it indicates future socioeconomic status. And we have to keep in mind the average age of these decedents is 43. And that leaves about 20 years of time for them to go back and get that GED. There's definitely time for them to do that. And I think that's something that could be worked on. And then when I looked at the number of people who had the high school diploma or GED, it ranges at just below 50%. And so if we add those together, about 75% of decedents who fatally overdosed have a high school diploma or GED or less. And again, that extends to insecure housing, lack of access to healthcare, and then financial security. Decedent using substances alone, I just find using substances alone as not using them in the presence of someone and not telling someone that they were going to use. So maybe they were in the same house, but let's say the decedent didn't tell their friend that they were going to go use. They just went into their room. So that person that could have intervened and called EMS or administered Narcan wasn't aware that they were using at that time. So we see a huge increase in the incidence graph from March to June, where people were using alone. And I'm assuming this has to do with the social distancing. But then when we look at the percentage graph that takes into account the number of people that overdosed during that time period, it is the same, on par with previous years. And so, yeah, the worry with that was the social distancing during COVID. And that's a huge risk factor for fatally overdosing, because again, no one can tend to you if you overdose. There's research that shows that people that inject in public settings are almost 5 times less likely to overdose than those who inject in private settings. I want to talk quickly about a harm reduction aspect to using substances alone. If someone does want to use our alone, our office suggests that they use in a lazy boy, or they're in a position where they are not at risk for slumping forward onto the face. And I say this because when you're using opioids specifically, there's an increased risk for positional asphyxia. Our office put out a research article that compared natural deaths to opioid-related deaths, and we found that those who died from an accidental opioid overdose were more likely to have been found face down in the blankets, in a pillow, on the couch. And since opioids already depress breathing, coupling that with positional asphyxia increases the risk for death. I read a police report where an officer found an individual. My dog is snoring, I'm sorry. A police officer found an individual who we later found out had high levels of opioids in their system, and their chin was down to their chest. And the officer noticed that they had very slow, labored breathing. But when the officer moved their chin up to assess the decedent, their breathing immediately became stronger. So just that simple chin tilt compared to having your face in the pillow, it could be a huge factor in harm reduction in the future. And employment status, I define this as being unemployed at the time of death. And so we know that a lot of people were furloughed and laid off during COVID. And we can see a huge spike in March to about June where a lot of people were unemployed. I think this probably is similar to the general population. Excuse me. Having no employment just leads to more financial insecurity. There was a study that showed that those who were in more economically disadvantaged zip codes that they indicated as unemployment and lower education were more at risk for opioid overdoses. But then when we look at the percentage graph, it's about the same as seen with previous years, where over 50% of decedents are typically unemployed at the time of their fatal overdose. And then to still illustrate the poverty piece a little further, I separated the urban and rural communities, counties out, where there's about 2 to 2.5 deaths per 2,000 in all the counties combined. And then the rural counties, there's 1.5 deaths per 2,000, which is doubled in the urban population of 3 per 10,000 in 2020. This graph just kind of lays out the temporal aspect of that. And then on the right, that graph shows the specific percentage of people living under the poverty line. Urban communities, an average of 15% of people live under the poverty line, whereas rural counties, about 13% live under the poverty line. Impoverished communities are more susceptible to stress than wealthier communities. And that's because of the social circles, the access to substances, and the established drug networks just make it easier to access the substances. And it's harder to complete substance abuse treatment plans when there are high levels of daily stressors like unemployment and poverty. And so kind of my theory with this is that perhaps in urban settings, the treatment centers are close by, but they're not able to be accessed because of finances. And perhaps in rural settings, the finances are there, but the treatment centers are far away. And there are studies that show that financial barriers prevent residents from accessing the treatment programs. So mental health. Before I get onto that, the next 3 slides are just from 2020, just so we're aware. Mental health is super important during the pandemic. It was really scary at the beginning, and especially for the mental health professionals. The blue tabs indicate the data from 2020 from our office for the decedents, and the black bars represent the general population. So suicidal ideation and attempt for the general population represents someone who is 18 or over that ever had suicidal ideation or attempts in 2019. And then the black bars for each of the mental illnesses in the general population is that person ever being diagnosed with that mental illness. So for example, it was about 8% of people in the general population in the US have ever been diagnosed with depression. And about 1 or 2% of people in 2019 that were over 18 years old ever had a suicide attempt. So I wanted to compare what was seen in 2020 with what has been seen historically in the general US population. We can see that suicidal ideation and attempt, depression, bipolar, ADD, ADHD, and schizophrenia were much higher than what is seen in the general population than what is observed in the overdose population. Those who have at least one diagnosed mental illness are 50 to 75% more likely to use substances than those without a mental illness. And I want us all to keep in mind that this is just what I could find in the medical records. A lot of times we're not able to get any mental health records. So I'm from Grand Rapids, so we can't get like Pine Rest health records, for example. And so I think that some of this is underreported. And then I also wanted to talk about the number of mental illnesses someone had. So I counted in my spreadsheet how many mental illnesses someone may have had. So for example, when it says number of MI, and then we go over to 1, 61 people had maybe just depression or just bipolar. And if we go over mental illness on 2, then maybe that person suffered from bipolar and PTSD. And that is significant because at least 57% of decedents had at least one diagnosed mental illness. Having a previous overdose indicates risky behavior. And so those who have overdosed in the past are more likely to overdose again in the future and have a higher likelihood of daily overdosing. Using substances, excuse me, I lost my train of thought. I was thinking perhaps the stress and boredom of the pandemic may have led people to use substances in higher quantities. It's hard for me to look at this temporally because the medical records in 2018 and 19 were not consistently available. And so I couldn't look back and see if every decedent in those years had an overdose. So I decided to get rid of that data because it was not reliable. But overall, we can see that about 1/3 of decedents who fatally overdosed have overdosed in the past. Having a PCP is really important to create a connection with the healthcare worker who can connect you with appropriate referrals and access to other resources in the community. In addition to just the general maintenance of the body, there's higher rates of hepatitis C and HIV in those who use their substances intravenously. About 50% of decedents do not have a PCP. This also lends to opioid prescriptions, where let's say someone has a traumatic injury or a surgery and they're prescribed an opioid in the hospital. But what happens when they don't have a PCP to fill that prescription again, or they're still in pain, but the opioid runs out? They've used enough, or they've used enough where their body has become dependent on that opioid. Also, I've read several stories where people had insurance changes or they lost their insurance and so they could no longer receive that opioid. So that person has a higher likelihood of turning to illicit opioids. And for 2020, I found that 25% of decedents' substance use started from a prescribed opioid, which is just an astounding number to me. 1 in 4 people in this population in 2020, their substance use started from prescribed opioid. I think that just lends to not prescribing opioids as much. Finally, the biggest factor that I found influencing the increased risk of overdose in 2020 was not using substances for 2 or more weeks, being substance free for 2 or more weeks. So we can see on the left, the incidence graph, there is a huge bubble increase of overdoses from March to June, where there was an average of 4 people every month in 2018 and 19 that were substance free before their fatal overdose. And in 2020, that number is up to 7. Though when we look at the percentage graph and take into account the number of people that overdosed each month, it's only slightly higher at almost 30%. To me, 1/3 of the people who fatally overdose being substance free for 2 or more weeks is an astoundingly high number. And I categorize being substance free as maybe the person was in recovery for years, and in March, the stress of the pandemic caused them to seek substances, or they were in jail or rehab and they were released early, and they didn't have access to their treatment facility anymore. The danger with being substance free for this long is that tolerance is lower. In addition, I've read a few studies that say that people may have to seek out a different drug dealer, and perhaps that dealer doesn't test for things like fentanyl, or they use a different chain of substance trail. So I don't think overall that this was the main contributor to the increase in overdoses, but it definitely played a role. And I will illustrate what I think played the biggest role shortly. So then categorizing treatment center, and then I'll talk about recently released from jail. Those were 2 very popular reasons for people to have overdosed at the beginning of the pandemic. And we can see a little blip from March to June on the incidence side of the chart, and that remains on the percentage side of the chart too. A lot of decedents were told that they had to leave their treatment center or their social support group because they couldn't meet any longer for social distancing. So what are they supposed to do? It's hard to overcome this on your own. And if that support has been working for so long and then all of a sudden it's gone, that's a shock to the system. Being recently released from jail was a very common theme at the beginning of the pandemic that I was, when I was reading through the MBI narratives. I don't think it contributed to all 40 additional deaths, but it definitely contributed to a large portion of them. When you're in jail and you're released early, you may not have had the same connections to treatment, especially because those facilities were closing down. And perhaps due to other factors such as unemployment and using a loan, those people were at a higher likelihood of fatally overdosing. So while I believe it was the right decision for people to leave jail to lower the risk of COVID infection, unfortunately, this early release only further exemplifies how important it is for people to receive treatment, and that jail does not heal substance use disorders. And so I kind of look at these charts as an experiment where we have 2 groups, a randomized control experiment, where you have the control group and the treatment group. So the control group is made up of people steadily being released from jail throughout the year. And then the experimental group is releasing that same number of people throughout the year within just a few months. And that is what we saw in 2018 through 2020. So the control group is 2018 and 2019, and the experimental group is 2020. I hope that makes sense. I can explain it further if there are questions. And according to the Department of Corrections, from March to June, about 5% of the prison population was released early, which translates to about 2,000 people. And then the department, the Bureau of Justice Statistics estimates that close to 60% of people incarcerated in state prisons and local jails meet criteria for substance use disorders. Then other studies have found that individuals that were incarcerated face an increased risk of death from overdose, especially if an opioid is involved upon their release because of that period of abstinence that they experience while in custody, and then the lack of social and financial support upon reentry into the community. And then finally, the last fact I will lead you with is that drug-related deaths after release, people are 3 to 8 times more likely to fatally overdose following the 2 weeks after release from jail. So those first 2 weeks after release from jail are the most important in getting people resources such as Suboxone, buprenorphine, etc. There were a lot of questions at the beginning of the pandemic about the number of suicides that were going to occur. And I can say confidently that that is not true. More accidents occurred this year in 2020 compared to 2018 and 2019 by overdose modality. I don't know other modalities yet. Those should be released by our office very soon. And the number of suicides actually went down to about 6% per month, about half. So usually we would have about 2 suicidal overdoses in 2018 and 19 per month, and in 2020 we had on average. And so then I want to talk about substances in the community and how those are surveyed. So we'll talk about existing substances, new substances, and substance combinations. So first we'll talk about stimulants. So methamphetamine doubled from 2018 to 2019, where it was about 16% of deaths were due to methamphetamine in 2018, and almost 1/3 were due to methamphetamine in 2019 and 2020. Cocaine has declined just a couple percentages. Methamphetamine is something that we need to start tackling. The doubling from 2018 to 19 is startling, and it's further exemplified in the substance combinations that we'll talk about. So now we'll talk about opioids real quick. Fentanyl, of course, we know that that's the most dangerous in terms of street use. And it has increased by about 20% from 2019 to 2020. And I think this has a lot to do with the increase in fatal overdoses in 2020. Then heroin remains around 20% causing death. There are some new emerging substances that our office has come into contact with. So the first is parafluorofentanyl. In 2018 and 19, our office did not find any cases of this, though it was being tested for. That's very important to know, because then in 2020, we found 4. And so far in 2021, I checked today, we have 22 cases that have been detected. Though not all of these have been confirmed, but they're basically confirmed. Xylazine was not tested in 2018, but was in 2019 and 2020. Xylazine is a veterinary drug that is used for sedative and muscle relaxation, and it's reported to have like heroin-like effects. It's typically not super harmful to humans in low doses, but it gets harmful obviously in higher doses, but then when that xylazine is coupled with other substances. And it's interesting how this has kind of moved from the east side of Michigan over to the west side over the last couple of years. So in 2019, there were 6 cases, and in 2020, there was 13 cases. And so far today, again, I checked, there are 9 findings, and we're not even at the halfway mark of June. So I suspect there to be around 20 by the end of the year at the rate we're going. At least 20, I should say. So substance combinations, methamphetamine and opioids, obviously a stimulant and a depressant, they're very dangerous when together. also dangerous alone, but they put the body in a state of confusion and people are more likely to share needles, which then leads to other health effects such as hepatitis C and HIV. A study found that there was almost a 3 times increase of overdose when injecting heroin and methamphetamine versus just heroin. And then those researchers also found that fact that those who inject methamphetamine and heroin together were more likely to share their needles. It is thought that people use methamphetamine and illicit opioids together to come down from the methamphetamine high. So I've read several stories where people are using methamphetamine for several days and they want to come down from that high, and so they inject heroin or their illicit opioid. Others like the feeling of methamphetamine and opioids together in their system, having that stimulant and depressant. And then again, I like to show different types of ways to show the data. So we can see that in green, those are the total methamphetamine deaths, regardless of any other substance found in the decedent's toxicology. So that number has doubled, more than doubled from 2018 to 2020. And then we can see the proportion of people that have any type of opioid in blue and methamphetamine has remained about the same. So about 60% of people have had their methamphetamine and an opioid found in their system contributing to death. And then I wanted to stratify out heroin, and we can see that a smaller percentage of people had methamphetamine and heroin. I think that makeup between the blue and the pink is fentanyl. So for example, in 2018, 16 people may have had methamphetamine and fentanyl instead of the heroin in their system. So I'm not sure if there's an increasing trend or if the opioids are just continuing to get stronger. Something to be studied for sure. And then finally, an overview of substances contributing to death. It's kind of hard to see, but the top orange line is fentanyl, and that has skyrocketed from 2018 to 2019. The next one is methamphetamine in green, which is steadily increasing. Heroin and cocaine and those light blue colors, they have remained relatively stable over the past 3 years. Xylazine and parafluorofentanyl are steadily increasing, and is something that medical examiners and other people who are involved in drug-related deaths need to keep their eye out for. So then to wrap everything up, what do we do with this information? There needs to be a quick turnaround for access to services after a non-fatal overdose and after being released from jail or prison. If someone has non-fatally overdosed, they are at higher risk for fatally overdosing in the future. So we can connect them with services, either when EMS tends to them or they're in the hospital, connect them with a social worker who can tell them their options for treatment. And obviously it's up to that person if they want to accept that treatment, but giving them the options and bringing the services to them to make it as easy as possible for them to learn their options. And then being released from jail and prison, I mean, there needs to be reform in this. I can't say anything more about it. And we also need to continue to push public opinion towards substance use disorder as a disease and not a choice. And I think that we can also do this by lowering the number of opioid prescriptions given to people, and give alternatives. There has to be alternatives. There needs to be alternatives created. Continuing with injury prevention. So that's needle exchange programs, and then telling people to use their opioids in like a lazy boy or something, so that they are not at risk of asphyxiating themselves. And then finally, continuing to focus on methamphetamine use. It's starting to increase a lot, and combining the use of the illicit street opioids and methamphetamine is incredibly dangerous, as exemplified by that. So finished a little early, but maybe we can have more in-depth discussion and questions now.
Wonderful. Thank you, Chloe. Thank you so much.
Yeah.
We do have some questions in the Q&A, and as we're discussing, please enter your questions and we'll answer as many as we can. So the first one up, Chloe, it says, great presentation. I'm interested to learn more about fentanyl. How do you recommend we utilize fentanyl test strips?
Yeah, that's a good one. I think maybe, I don't know if this is done, so forgive me, but at the needle exchange facilities, perhaps those can be given out with the syringe exchange. Just making it more common for people to have on hand when they're using at their home or wherever they're using. I think that could really help for sure.
Okay, super. All right, and someone asked, can you please tell me what county the data was pulled from?
Yeah, so that would be 11 counties, Allegan, Berry, Calhoun, Grand Traverse, Kalamazoo, Leelanau, Osceola, Mason, Muskegon, St. Joe, and Van Buren. That should be all 11. Yeah.
Yep. So it was a mix of those 11 counties. So all of
Mhm.
the data for each individual county would have been blinded because this was a multiple county data. Okay.
Yeah. Yeah.
Okay. Super. I can answer the next one. Will we receive a link for the recording? Yes. And the next one, when is it available? The recordings will be available probably next week. So we'll send them out. Okay. Can you speak about data regarding deaths due to alcohol abuse?
Not right now. I am working on the yearly reports for each of these counties, and I'll have a little bit of information in there about alcohol abuse. But admittedly, I haven't focused on that this year, but it's something I'm working on in 2021. So hopefully at this time next year, we can have more information about alcohol abuse. I can say typically our office signs out 3 to 4 death certificates a month that were related to acute and chronic alcohol use.
Okay. Great. Super. Okay. All right. I'll give us some time as we think of other questions.
Oh, I see another one. What is the reason Kent County was not included? Our office doesn't do medical examiner services for Kent County, so I don't have access to that data.
Okay. All right. Very good. All right. Do you want to talk a little to explain that, how we may, just to help us all have a clear understanding about how the medical examiner offices are regionalized across our state?
Yeah, how do I start this? So Dr. DeYoung, our chief medical examiner, starts, gosh, it's up to the counties, it's up to the county commissioner to decide who their medical examiner will be. And so the reason that we added Berrien and Cass County is because those county commissioners and then the previous signing physician for death certificates decided to have a forensic facility perform the autopsies and determine what is written on the death certificates. So Dr. DeYoung can like fight for other counties and say, hey, we should do your medical examiner process, but it's ultimately up to the county for them to decide.
Okay. Okay. Perfect. Thank you. Thank you. Okay. Are people getting drugs in the mail more now versus person to person? I wonder if COVID changed drug access.
Oh, that's interesting. I remember reading one MEI narrative that said that someone received their substance in the mail. And a lot of times, now that I think about it, a lot of times the acquaintance of the decedent would tell the MEI that they didn't witness the decedent leave the house and no one came to the house. And so either that person had a stash of substances or they did just go out to the mailbox and grab it. That's interesting. I don't know if I'd ever be able to track that well enough to want to report on it. Um, but I can keep my eye out and see if I notice any patterns.
Wonderful, thank you.
Yeah.
A compliment. Thank you so much for your presentation. Very informational. And then the little slide for Go Broncos.
Yeah. Yeah, thank you. I appreciate that. I was a little nervous, so I appreciate that.
All right. Okay.
And then, like I said, I was working on yearly reports for each of these counties. So if you do work in these counties, you can email me and I can send you those reports when they are finalized. And it includes all of this information plus more, so that you can use it for whatever purposes, getting more money from grants or just learning what is going on in the community.
Okay. All right. And Chloe, if you would just put your email in the chat and then people
Yes.
can have that, that'd be great. Thank
Yeah.
you. Okay. There were several questions about what CEUs are offered today. And throughout this series, there will be CEUs for medicine, which includes nursing, social work, and then substance use disorder CEU credits. Okay. Chloe, I'm not seeing any other questions at this point in time. So thank you ever so much for your presentation. And we just appreciate it so much. And I don't know about those in the room, but I know that the CMREN people are really hoping that there's a way we can get this level of data with your analysis applied to it for many other counties in the state. So,
Yeah.
so
Hoping every day for that.
yes, yes,
One day. Yeah.
one day. So,
One day.
so
Well, thank you for inviting me. I appreciate it. I feel so
yeah,
honored.
yes, it's been wonderful. Thank you ever so much.
Yeah.
Thank you for those attending, and we will be having those links posted, and we'll actually probably have them sent to a YouTube, so they'll be posted as YouTubes from the Ferris site, and then we will send those out as we can to attendees. And CMREN will be having our website launch in early June, and these will be available on our website as well. So thank you for attending, and we look forward to having you join us for the rest of the week. Thank you so much. Have a great day.